It is my great honor to introduce to you our last speaker of the summit. And let me just tell you, we have had some incredible giants at this summit, but we saved the best for last. Dr. Hotez is an amazing man, probably the smartest person I have ever met and will ever meet. He is absolutely in a class of his own in terms of his accomplishments. His bio is several pages long, and his achievements are just remarkable. You've probably seen him a lot on TV lately because he has been all over the place talking about Ebola. It is one of his specialties. He is now a member of the governor's task force on Ebola. He rode the subway on MSNBC with one of the reporters. He's just been everywhere on Ebola. But his real passion is neglected tropical diseases. And Dr. Hotez is a man who has and will continue to save lives of the poorest of the poor and to make a difference in this world that few people have ever really gotten to make. He is, I will add, among his many accolades and accomplishments, he's also a member of the TIP board. Yay. I know it's not on the top of his resume. It's there somewhere though, I'm sure. I'm just going to give you a little bit of a sense of what I'm talking about. Dr. Hotez is the founding dean of the National School of Tropical Medicine and professor of pediatrics and microbiology, molecular virology and microbiology at the Baylor College of Medicine, where he is also chief of a new section of pediatric tropical medicine and the Texas Children's Hospital endowed chair of tropical pediatrics. He is the president of the Sabin Vaccine Institute, director of the Texas Children's Hospital Center for Vaccine Development, and the Baker Institute Fellow in Disease and Poverty at Rice University. Dr. Hotez is an internationally recognized clinician and investigator in neglected tropical diseases and vaccine development. He leads the only product development partnership for developing new vaccines for hookworm infection, schistosomiasis, and Chagas disease, diseases affecting hundreds of millions of children and adults worldwide. Dr. Hotez is the founding editor-in-chief of the PLOS Neglected Tropical Diseases, a fellow of the American Academy of Pediatrics and the American Society of Tropical Medicine and Hygiene. He is a member of the Institute of Medicine and the National Academy of Sciences, the Association of American Physicians, the Academy of Medicine, Engineering and Science of Texas, and in 2011, he was awarded the Abram Horowitz Award for Excellence in Leadership in Inter-American Health by the Pan American Health Organization of the World Health Organization. Dr. Hotez has also written about a daughter with autism and special needs as his public role as a developer of neglected tropical diseases. Oh my goodness, what a mouthful, and what a man, what an incredible man. We do have one thing to add for you. We have a disclosure that is not in your packet, not included in the disclosure form in your packet. We need to disclose that Dr. Hotez has a patent on the vaccines that he will be discussing. And without further ado, I would like to bring you the famous Dr. Hotez.
Wow, what an introduction. That was amazing. Anytime you ask me to speak, Ann, I'm gonna do that. Unfortunately, now we're out of time because we like to say in our field, when we work on neglected tropical disease vaccines, that we aspire to have conflicts of interest because our vaccines target the world's poorest people. And unfortunately, our important public health technologies, but will not bring anything in the way of financial remuneration. Anyway, it's very nice of you to have me here, and I'll try to be relatively brief to describe this interesting space. of neglected tropical disease vaccines. And I'll talk a little bit about Ebola in order to put it into a larger context. And I'm going to start here, which is a document that not a lot of people know about, but it's actually been a real game changer in terms of making an impact on the lives of the world's poorest people. So there's a term out there called the bottom billion. It refers to the fact that there are about 1.4 billion people in the world who live on no money, who live below the World Bank poverty figure of $1.25 a day. And around 15 years ago, in 2000, Kofi Annan, who was Secretary General of the United Nations, said, you know, we really need to do something about the world's poorest people. And he asked all global leaders to come to the United Nations headquarters in New York, which is the first time this had happened, to draft a set of goals in the year 2000 called the Millennium Development Goals to address the plight of the world's poorest people. And what's nice about this document is, unlike so many other United Nations documents that are out there where people forget about as quickly as they're drafted, this one has stuck and has really provided a framework for big picture interventions. They include big initiatives for improving child mortality through increased use of measles and Haemophilus influenza vaccines. Somebody finally figured out that addressing the plight of girls and women is important to addressing poverty. So there's two far-reaching development goals for girls and women. Number 3, to promote gender equality and empower women. Number 5, to improve maternal health. And there's number 6, which is the one we'll focus on, which is to address specific infectious diseases, to combat AIDS, malaria, and other diseases. And this one has had a huge impact because it helped launch President Bush launching the President's Emergency Plan for AIDS Relief, which has put multi-billion dollars out there for putting the world's poorest people on antiretroviral drugs. It also created the Global Fund to fight AIDS and malaria, which is a multi-billion-dollar fund based in Geneva. And so it got not only people on antiretroviral drugs, it provided anti-malarial drugs and bed nets. And it also created a whole generation of global health celebrities like Bono and Brad Pitt and Angelina Jolie, George Clooney, all addressing the bottom billion in terms of the impact of these diseases. But that's not actually what I came to talk to you about today. I came to talk to you about something that somebody, I don't know what they were thinking, called the other diseases. And it turns out that most of the world's poor people suffer from other diseases, which unfortunately got called other diseases because from an advocacy perspective, you could imagine what a disaster that was, right? You don't see Brad Pitt standing up there and saying, now, other diseases. It just never happened. And so these are what I came to talk to you about. These, we got together, a few of us who are working on these other diseases, and branded them as the neglected tropical diseases, or NTDs. And these are 13 or 14 tropical infections that are highly prevalent among the poor. Many of them are ancient afflictions, have been around since biblical times. Oftentimes they're killer diseases, but others are chronic and disabling. And many are disfiguring and highly stigmatizing, and we've seen that with Ebola as well, which is highly stigmatizing. And very important, they are poverty promoting. And by that, I mean these diseases, for mechanisms which I'll show you, not only occur in the setting of poverty, but they're a stealth reason why the bottom billion, the poorest people in the world, can't escape poverty. So we put this list together, and I wrote a book about these diseases, which my kids like to call Dad's Forgotten Book on Forgotten People, those forgotten diseases, although now it's in paperback now. And to get the word out about these, and we're starting to make a little bit of headway. And we've recently now got together with a cast of about 20 other scientific investigators to accurately determine how many people actually have these diseases. And so what I'm going to show you now is this list of the most common afflictions of poor people and how many people are actually infected. And I sometimes like to call them the most important diseases you've never heard of. And everybody's heard of Ebola now, but how many people have heard of ascariasis in this group? So 1, 2, 3, 4, 5, 6, 7. 7 people. So ascariasis is the most common affliction of poor people. 819 million people have ascariasis. Anybody want to tell me what it is? It's roundworm, intestinal roundworm. So some of these are wormy diseases, parasitic worm diseases. So let's go down the hit parade here. Trichuriasis, 465 million. Hookworm disease, 439 million. Schistosomiasis, 252 million. Now you notice that number adds up to more than 1 billion. So what is that telling you? Some people have more than one, right? People are polyinfected or polyparasitized. Lymphatic filariasis, also known as elephantiasis, onchocerciasis, foodborne trematodiasis, and I could say them faster than anybody. Cutaneous leishmaniasis, Chagas disease, trachoma, cysticercosis, echinococosis, dengue, visceral leishmaniasis, African trypanosomiasis, rabies, yellow fever, yaws, Buruli ulcer, and finally Ebola. And what we're saying is that every single person living in poverty has one or more of these diseases. And their effects are quite interesting. The orange bars represent neglected tropical diseases that are killer diseases like Ebola or rabies or dengue. But a lot of these tropical infections are not necessarily killers, but they're disablers. And this color-coded graph basically shows where you see the blue are diseases that are not necessarily killers but disablers, whereas the orange are killer diseases. And you can see there's more blue there than orange. And this is one of the reasons why these diseases are neglected, because they're not killer diseases. So it takes time for people to understand why they're important. And I'm going to try to kind of bring that home for you now. So let's take the most common neglected tropical diseases, ascariasis, trichuriasis, and hookworm infection, which are color-coded here in the yellow, green, and blue. And what I'm showing you is a study, and if you remember, these are more than 800 million with ascariasis, 400 million with trichuriasis and hookworm. And what I'm showing you is the prevalence, the percentage of people that are infected in this particular village of Paquila in Guatemala we were working. And then I'm showing you on the x-axis age class, 0 to 3, 4 to 7, 8 to 12. And you can see that all of these kids pretty much are infected with ascariasis and almost as many with trichuriasis or hookworm. The point being that we can repeat this in almost any rural village of Guatemala or Belize or Honduras or Nicaragua or El Salvador, or go into Venezuela and Brazil, go across the ocean to Southeast Asia and Cambodia, Vietnam and Laos, or go into Western China or into South Asia, into India and Bangladesh and Burma, or go into Sub-Saharan Africa and Angola, Nigeria, Democratic Republic of Congo, and what you'll find is every single child has worms. Every single child has a neglected tropical disease. And what's curious is what I'm trying to show you on the right-hand side of the graph, which is kind of a wormy curve. It's age on the x-axis and number of worms on the y-axis. And you can see that while everybody in these endemic areas is infected with worms, it's the children who have the largest numbers of worms. There's a peak period of worminess between the ages of, say, 4, 5, and 15, when children have more worms than any other age group. So you get this little girl from Paraguay is on the left, and on the bottom are the worms from that one little girl. And so that's which is pretty impressive. Why is that? Why do children have more worms than adults? People are going like this, putting things in their mouths. Any other hypothesis? Going barefoot. Any other hypothesis? Actually, 2 of the parasites are actually orally infective, so it's probably not barefoot, but it's a good thought. Immunity, yeah, maybe as you get older, there's some kind of immune response kicking in. This is a trick question. I have no idea. These are neglected tropical diseases. Nobody studies it. So the most common afflictions of the world's poor, and we don't even know why kids are more at risk than adults. And look at the impact. Most of the time, these worms don't kill. But what I'm showing you is a bar graph there where I have different ranges of the number of worms that they have. And on the y-axis is the loss of intelligence. It's basically showing worms shave off IQ points. Worms make kids stupid, which we're trying to understand why that would be, because the worms are in the intestine, not the brain. Why is it shaving off intelligence? Maybe something to do with malnutrition, but we don't know. And they're also impairing physical growth. So this is a growth curve that you would see in any pediatrician's office, and you can see there's flatline growth in the red until we get rid of the worms and the kids start growing again. And the consequence, again, is that not only are they affecting health, but they're affecting economic development. So now the economists have come in and shown chronic hookworm infection in childhood reduces future wage earning by 40%. So in this case, it's probably because of the effects on intelligence, it's trapping people in poverty. And this is a common theme that we see with all the neglected tropical diseases. They're a stealth reason why they cause poverty. Another one, which is a big problem in Latin America and in Mexico, and will come back even in parts of the United States, is Chagas disease, which is a parasitic cause of heart disease that's transmitted by that lovely-looking cockroach-like bug there called the kissing bug. This one causes $7 billion in annual losses from healthcare costs or because people are too debilitated to go to work. Globally, in over $1 billion in North America alone. So this is what's trapping the poorest people in the Western Hemisphere in poverty. So the point being that when we look at now, we had an original list of 13 or 14. The World Health Organization has jumped it up to about 17, and these both occur in the setting of poverty and cause poverty because they reduce productive capacity, they make people too sick to go to work every day, impair intellectual development in children, disproportionately affect girls and women. Maybe we'll come back to that. This idea that the NTDs, the neglected tropical diseases, are the major reason why poor people can't escape poverty because they're all widely infected. We're now starting to realize this horrific impact on girls and women especially. This is an analysis that we've recently done for a disease that used to be called urinary tract schistosomiasis. It's a parasitic worm infection affecting the bladder. It causes blood to appear in the urine, especially of kids and adolescents. And we called it urinary tract schistosomiasis because it was neglected in the sense that nobody ever bothered to do a colposcopic exam, a vaginal exam on the girls and women with this condition. We now realize that half of them have these lesions on their cervix, their uterus, their lower genital tract. It's a condition called female genital schistosomiasis, and we estimate now 100 million girls and women in sub-Saharan Africa have this condition. So I think it's Africa's most common gynecologic condition that you've never heard of. So it's, and we now, colleagues in Norway and New York working in Africa have shown that this may be one of Africa's most important cofactors in its AIDS epidemic because of the ulcerative lesions it's producing in the genital tract of girls and women. It's providing avenues for HIV to enter into the body and set up disease. And we've been very focused on things like condom use or abstinence or putting people on antiretroviral drugs, all very important, but we've ignored what may be the most potent cofactor in Africa's AIDS epidemic, being schistosomiasis. The other interesting feature we've found about these diseases, we call them tropical diseases, but they really first and foremost are diseases of poverty. But it's also poverty and conflict, and now we're started to realize this interesting link between conflict and contagion. So wherever we're finding civil or international wars appearing, neglected tropical diseases almost invariably follow, and many of them with lethal consequences. So one of the most dramatic examples is the Ebola outbreak in Guinea, Sierra Leone, and Liberia. There is as you know, there's now been more than 10,000 cases of Ebola virus infection, with at least half of those people dying, more than 5,000 deaths. And we're having a lot of trouble getting this epidemic under control. And one of the things that I say is while I'm very worried about Ebola virus infection in West Africa, I don't think it's going to come to the United States in a serious way. I do not think we'll ever see an Ebola outbreak in the United States, and we can, afterwards have more of a discussion of why that's the case. But why did it take off in Liberia, Guinea, and Sierra Leone? Well, it had to do partly with the fact that these countries have emerged out of horrific conflict during the 1990s and into the first part of the 21st century. And as that conflict started becoming more and more widespread, it forced people to abandon their lands and to go into forest areas, deforest those areas in order to raise crops and build homes. And it's there that they came into contact with fruit bats, is our current prevailing theory. And fruit bats harbor the Ebola virus, and this provided unprecedented contact between bats and people. And that's one of the reasons why it first ignited in Guinea. And then it was fueled by the fact that all those years of conflict made it impossible to create any kind of healthcare infrastructure. So it turns out when you're first infected with Ebola virus, it's not very contagious at all. In fact, on TV, we retraced the steps of the Ebola doctor who was in Bellevue Hospital, and we went on the A train from Columbus Circle to Harlem, and I explained why you are at risk of getting rhinovirus, the common cold, and influenza, but not Ebola virus infection. It's only when you come in contact with people with the advanced disease that harbor huge amounts of virus that you get into problems. And here was the problem in Liberia, Guinea, and Sierra Leone, is we had no place to place patients in any kind of hospital where there was adequate containment and personal protective equipment. And then healthcare providers started getting it, or those who couldn't get loved ones to the hospital and had to take care of individuals with very advanced illness at home got it, and then burying the newly dead, because by the end of your life, you have a huge amount of virus all over your body. And this is the reason why it's taken off there. But the starting point was conflict. And one of the things that I will often say when I'm on television is this is not unique. This is a pattern that we've been seeing now for decades. Wherever you have high rates of conflict in the setting of poverty, you invariably will see lethal or sublethal outbreaks of neglected tropical diseases. So another example was in the countries in red, in Angola, Democratic Republic of Congo, and Sudan, where during the 70s, 80s, and 90s, more than 500,000 people died every year of a neglected tropical disease called African sleeping sickness. And it had to do with the fact that there was, again, complete breakdown in public health infrastructure, so that all of our gains that we had made in sleeping sickness were reversed. This is a graph starting in, I know the print's a bit small, starting in 1927 on the bottom, going up to the present day, and the number of cases on the y-axis. This was a disease that's caused by tsetse flies and transmits a parasite called the trypanosome that goes to the brain and causes a fatal disease called sleeping sickness. It was a disease that at the bottom of the graph, in 1960, we had practically eliminated as a public health problem. But then with the independence of Congo, the formation of Zaire and the reign of Mobutu, and then widespread conflict there in Angola and Sudan, we went right back up to 1920s levels, and only now are we starting to get it under control. And we're seeing this again. We saw it again now in the 80s and 90s in South Sudan with another disease called Kala-Azar. And so I think an important message here, and then again now we're seeing it with Ebola. So an important message here is wherever the international community sees widespread conflict and poverty, something bad is certainly going to happen. So one of the things that I've been talking about would be nice to anticipate when the other shoe's going to drop and where the other shoe's going to drop. So where's our next big conflict zone that we're worried about? The Middle East, and specifically in Syria and Iraq, where all of the same conditions. We've got the perfect storm ready for a major outbreak of infectious disease. We have terrible poverty, complete breakdown in public health infrastructure. We've already seen now the emergence of cutaneous leishmaniasis, which has been disfiguring little girls, the reemergence of polio and rabies. And so this is something I think we have to anticipate as well, because it's all along the same spectrum. So with that in mind, we've been doing a deeper dive into where these neglected tropical diseases occur. And I'm showing you kind of a color-coded bar where we actually, in detail, looked at where each neglected tropical diseases occurs. And while we assume that it's going to be a big problem in sub-Saharan Africa because of all the poverty there, and it is, we also found something really surprising, which is that a huge amount of neglected tropical diseases actually occurred in wealthy countries. including G20 countries, the group of 20 countries, the wealthiest economies. And where we found it occurred were not homogeneously distributed in wealthy countries, but wherever you found poverty congregating. So this is a new map of global health. You know, it's not your father's global health where you looked at developing versus developed countries. But actually what we're finding is we're rapidly growing economies in Africa, with a few exceptions like in West Africa and everywhere else, but leaving behind a segment of society that has no money. And there's where we're finding the highest concentrations of these neglected tropical diseases. So we see Nigeria there, or look at India. It's not all over India, it's more northern India. Or in China, more in western China. So it's not so much that you're having neglected tropical diseases on the East Coast in Shanghai and Beijing, but it's western China, which is still highly underdeveloped. Or in the northeastern part of Brazil, or in northern Argentina, or in southern Mexico. So does anybody see anything there that kind of strikes out as kind of funny looking to you? Yeah, look at the southern part of the United States. So there's poverty there. And we actually call this concept blue marble health, to give it a different name from global health, to remark on the fact that it's wherever you find poverty, we're finding diseases. So one of the things that we did when we set up our National School of Tropical Medicine in Texas, there's a reason we're in Texas, which is that we took our global health lens and turned it inward on ourselves. And what we found was a very surprising amount of neglected tropical diseases. So on the upper right is a risk map done by a colleague of ours at the University of Texas, Dr. Sarkar, of Chagas disease in Texas. So we're finding a fair amount of widespread disease and actual transmission of the disease, and that's important because when I start talking about neglected tropical diseases in our state, what's the first thing people are going to jump up and say is the problem? Yeah, people are going to blame immigration. We need to build a wall higher. But what we're finding, for instance, in Texas, is about 8% of the dogs are infected as well in this region. So the dogs are not slipping in across the border from El Salvador and Mexico. The dogs have been here. So the point that we try to emphasize over and over again is that we have transmission of these diseases primarily concentrated in area poverty. That bar graph on the bottom is a study done by one of our faculty, Christy Murray, who found that dengue fever emerged in Houston in 2003. And what's interesting about it, it wasn't all over Houston. It was mostly in areas like the 5th Ward of Houston. Why is that? People say it's a poor area, but what is it about poverty that promoted the emergence of dengue in the 5th Ward? Tires full of water, somebody said. I think that may be onto something, because when you drive, the truth is we don't know, and we're looking into it now. But we see the discarded tires along the side of the road filled with water. You see dilapidated housing. You see people without window screens, so they're more susceptible. We have both mosquitoes that transmit it. On the bottom left there, we estimate now that more than 12 million Americans with neglected tropical diseases. Most of them are among the 20 million Americans who live in extreme poverty, meaning at half the U.S. poverty level, and there's even now 1.65 million families in the United States that live on less than $2 a day, and most of that poverty is concentrated in the South. So one of the things we've done now is actually create a unique tropical medicine clinic in our school, not a traveler's clinic, although we have that as well, but a clinic for predominantly indigent people with tropical diseases, and we see them every Friday morning. So one of the things that people are quite surprised when they ask me about, am I worried about Ebola coming to America? I say, Ebola, we've already got 12 million Americans with neglected tropical diseases. Let me tell you about Chagas disease. And then, of course, they invariably say, oh, thank you, Dr. Hotez, but we're out of time. So it's an inconvenient truth that people don't want to hear. We're also finding globally a lot of these neglected tropical diseases in some of the world's Islamic countries, and this gets to what I was telling you about Syria and Iraq, where this is an example of one that's just completely out of control right now. It's a disease the locals call Aleppo evil. It's transmitted by a sandfly, and what it does is it doesn't kill, but it produces a disfiguring lesion on the face. And it's a disaster when little girls get it because it renders them unmarriageable, or it's grounds for spousal abandonment, or other horrors. And now there's been more than 100,000 cases, and it's even following the refugees fleeing Syria, going across the border into Jordan or into Lebanon or Turkey, and of course nobody can get in there because it's just too dangerous to do much about it. So I think the Middle East and North Africa is going to become the next big hot zone for neglected tropical disease because of all the instability. And people think, well, the Middle East is a pretty wealthy area, isn't it? Because they think about Saudi Arabia and Qatar and United Arab Emirates, but there are about 65 million people who live in extreme poverty in the region. And we're going to see those two forces again. And so we're now working in a very interesting way with the Department of State to look at what we can do about that. And part of it has to do with we need new interventions. And particularly, we need new vaccines. And here's the problem that we get into. Major pharmaceutical companies have been great about making vaccines that affect the United States, Europe, and Japan, and also scaling it up for some of the poorer countries in the world. But it's a business. There's a difficult business plan for what you do about the diseases that we've been talking about that have no traditional market, where there's nothing in the U.S., nothing in Europe, nothing in Japan. And so a classic example of that is Ebola virus infection. We had the technology for that vaccine more than a decade ago, but it sat on the shelf not being tested in people in clinical trials because of market failure. So our technology for making vaccines has outpaced our political, social, economic infrastructures to finance them and get them out. And in our business, we call this concept the valley of death. And what it means, if you look at the two sides of the valley, on the left-hand side of the valley is a big wall that represents all the basic research that's going on. And on the right-hand side, there's a fair amount of clinical trials capacity, but we've always relied on the major pharmaceutical companies to build that bridge in order to get new products out for the people who need them. And the drug companies have been good about donating repurposed medicines. They've done some forays into a few neglected tropical diseases like dengue, but for the most part, they've not really done this. And so we've been really racking our brains trying to figure out, do we need a new model for developing these vaccines? And what a partial solution for this was really helped invented by the Bill and Melinda Gates Foundation in the year 2000. And what they did, what I'm showing you here are the logos of 16 organizations that are called PDPs, Product Development Partnerships. These are nonprofits that use industry practices to make different stuff. By stuff, I mean these are on the left, diagnostic products, therapeutic products like small molecule drugs, microbiocides and preventatives, and even vaccines. And on the bottom are different categories. And these 16 PDPs, which some people like to call guaranteed money losing companies, have been set up across the world. Many of them are in Geneva to be near the World Health Organization, or others in Seattle to be near the Bill and Melinda Gates Foundation. And we have the only one that's based in Texas. And if you do the grid going up neglected tropical diseases, NTDs, and vaccines, you'll see something called the Sabin Vaccine Institute. And what we did was to bring the Sabin Vaccine Institute to Houston 3 years ago to be part of the Texas Medical Center. So we're named after Albert Sabin, who discovered the oral polio vaccine, who once said appropriately, a scientist who's also a human being cannot rest while knowledge, which might reduce suffering, rests on the shelf. And we brought it here because it's such an incredible powerhouse of biomedical research. And we set this up jointly with the establishment of a new school of tropical medicine with Texas Children's Hospital and Baylor College of Medicine. And so our PDP is located on several floors on the right-hand side of the Feigen Center of Texas Children's Hospital, and I invite you all to come and look, and where we have all of the things that you would see to us with a small and mid-sized biotech company, which includes process development and scale-up, formulation, adjuvant development, technology transfer. But what we're doing is making products for people who can't afford to pay for them. And it's a very different mindset. So we only use ingredients that are extremely inexpensive, or technologies that are extremely inexpensive, because the economists that we work with say, we cannot charge, $100 a dose, which some vaccines are. We have to keep them around $1 or $2 a dose if they're ever going to be used by the world's poorest people. So we build in low-cost processes from the very beginning. So let me tell you about a couple of vaccines we have. We have a human hookworm vaccine that's highly prevalent among the poor, about 400 million cases, a leading cause of anemia. That's actually what it looks like. It's about 1 centimeter long and extracts blood. So we have a lot of technical problems, too, making a vaccine against something that looks like it could bite off a piece of your finger more than anything else. And it's in the intestinal tract, almost like a leech, and causes blood loss. And we've worked out the mechanism by which hookworms use to feed on blood, and we've made a vaccine extracted from hookworm blood-feeding antigens that are then genetically engineered in yeast or bacteria or even plants. And we've made a pretty promising vaccine that's now in phase 1 trials in Brazil, and now we've just got a new partnership supported by the European Union to work with the Albert Schweitzer Hospital in Gabon, and I'll be going to Europe next week, because through this European partnership, we've started clinical trials in Gabon as well, and this could be a very important technology. And we've also developed the schistosomiasis vaccine, which we have filed an IND, and we're hoping soon to begin phase 1 clinical testing for safety, actually here in Houston at Baylor College of Medicine. So we have a new Chagas disease vaccine, and this is one of our first vaccines that potentially could be used both in the poorest countries of Latin America, but we're also finding it in Texas. And in this one, we're developing it jointly with Birmex, which is the public sector vaccine manufacturer in Mexico. So whenever possible, how we make the vaccine we think is as important as what we make. We try to make it jointly with developing country manufacturers in the disease endemic countries. And this one is supported by the Carlos Slim Health Institute. We have a vaccine for leishmaniasis, which we think could be important in use in the conflict in Syria. And that's actually something we've been looking at, is how we can look at how we can co-develop some of our vaccines jointly with some of the Islamic countries where there's very high rates of these diseases. Because right now, the Middle East and North Africa has almost no capacity for making vaccines. So the region is extremely vulnerable. So we've been working with the State Department, who is very interested to see how we could be developing things like a MERS vaccine, the Middle Eastern Respiratory Syndrome vaccine, jointly with countries in the Middle East. And the basis for it, and this is how I'll end, is an interesting story in what I call vaccine diplomacy. The idea that you could make vaccines between the United States and countries that you do not necessarily agree with ideologically. And it first happened with Dr. Albert Sabin, who many people don't realize it, but developed the oral polio vaccine jointly with the Soviets, with the USSR, and they did it at the height of the Cold War, right after the Sputnik launch. Both scientists from both countries, Dr. Sabin from the US, Dr. Shumakov from the USSR, got back-channel permission from their respective foreign embassies, Ministry of Foreign Affairs or the State Department, to cross the Atlantic, work together. And the oral polio vaccine that many of you took as kids, many of you may not realize, but it was actually first developed in the USSR, tested on more than 10 million Soviet school children, shown to be safe and effective in every Soviet citizen under the age of 20, and only then brought back to the United States for licensure. Then now it's being used to eradicate polio worldwide. And so this is a concept that now we're really looking at, working with the Mexicans on our Chagas vaccine, the Brazilians on our hookworm vaccine, and now maybe exploring what the next phase is going to be in the Middle East. So I hope to be able to come back to you, which I think is going to be the next hot zone in the world, to be able to tell you more about that next time. So this is where we have to piece together funding from a variety of sources. And I'll just end there to say, Anna, thank you so much for having me talk to you today and to give you a broad overview of this problem with the NTDs and what I think some partial solutions might be. Thanks so much. Oh, questions? Sure, happy to entertain a few questions.
Hi, my name is Dolores, and I was wondering, I can't help a lot, but I could help a little, and I'd like to know how I could donate to this program that you're developing vaccines for people who can't afford them.
Oh, that's wonderful. Thanks, and we'll be happy to come and show you the labs and happy to talk to you more about that. You can go. We work through Texas Children's Hospital and Baylor College of Medicine, and we always need external support. It costs a lot of money to make vaccines, and unfortunately, right now we're in a kind of flatline budget from the National Institutes of Health. So if we depended on the NIH alone, we wouldn't be able to be in working on our vaccines. So when we get funding from a variety of sources, the Dutch government, the European government, and also some high net worth individuals and foundations, and we kind of cobble it together every year. So any support would be deeply welcomed. Thank you. Yes, in the back there.
My question's on the possibility of the Ebola vaccine. Could you explain that again, about how it's not being done right now?
Well, so the science behind it has been around for more than a decade, and the problem with it is there's two vaccines that are at the forefront. One was developed at the U.S. National Institutes of Health, but it kind of sat there because there was no PDP that had funding to advance it, and at that time the major pharmaceutical companies weren't interested in it because it was a neglected tropical disease. When the outbreak occurred in West Africa, GlaxoSmithKline fortunately stepped up to start now to scaling it up and to aggressively advance clinical testing. The problem now is we lost 6 or 7 years when that vaccine could have been scaled up and developed, and now we have to have a very accelerated time frame where we do this now, what ordinarily would take years, to do it in a period of weeks to months. And we're in a bit of a race against time to see if, because we're at a very critical time now in the Ebola outbreak when the numbers seem to be just going up. There's actually some controversy of whether now we're starting to see beds open up in Liberia and it may be going down, or if it's still going up. If it's still going up, then it's going to be an incredibly we'll have to break all records in terms of accelerating the clinical development and getting a licensed vaccine out there. But it's too bad that we had to have this kind of crisis in order to hurry up so much that we couldn't do this over a measured period of time, because in principle we could have had a Ebola vaccine stockpiled and ready to go in time when we first noticed the epidemic.
So what others are possibly sitting on a shelf that need more funding?
Well, pretty much the laundry list of diseases that I showed you, at least half of them have vaccines where there's early stage technology being developed, like our hookworm vaccine that's now in phase 1 trials, or our schistosomiasis vaccine. But we're going to need either a major pharmaceutical company partner or extra financial support to get it all the way to the goal line for licensure and ready to go. So Ebola is just one of about a dozen vaccines that could be developed right now, but are not being developed. Interestingly, there is another one that the major pharmaceutical companies have taken on in a big way, which is for dengue fever. And I think there what we're seeing is now that we're in the middle of a global dengue pandemic, there is some market there that's incentivized the major companies to take this on.
With the Muslim religion really completely against immunization, so how do you find that if we develop something to help, because we think it's going to be the next big blowout, how do you think they would actually take vaccines?
So thanks for that question. So I do not think the Muslim religion is against vaccines. I don't think that's the problem. What we've seen is for political reasons, the Taliban up in Pakistan and Afghanistan have been aggressively trying to combat giving vaccinations to people, which is in some ways as a weapon for terrorism. There's possibly some blame that's been laid to our CIA for helping to fuel that, because as you know the story of in an effort to capture Osama bin Laden, there was a faux vaccine scheme created claiming that there was a hepatitis B vaccine, immunization, other childhood vaccine program going on. But I think it probably would have happened anyway, even without that. So we do have some terrorist groups that are assassinating polio workers, for instance, up in Pakistan and Afghanistan. But this is a minority. I think most of the Muslim world, parents want to see their kids vaccinated just like they do in the United States and elsewhere.
Dr. Hotez, thank you so much for your speech. Breaking news, the Ebola outbreak has now been declared over in the state of Texas. Yay.
Good job.
No, literally breaking news, just got it on my cell phone. And so I wonder, with all of the other neglected tropical diseases that you've shared with us today that are here in the state of Texas, what is your call to action for the stakeholders here today? Because Nidhi talked about that in her presentation for the Texas legislature and for public policy. What would be your call to action for people here around neglected tropical diseases in Texas?
Well, I think for Texas is right now these diseases are flying, the ones that are here already have flown completely under the radar screen. So the problems are pervasive in the sense that, first of all, very few people are even aware that these diseases are here. There's no real program being conducted now for active surveillance to go into affected communities. So why is that important? Well, somebody with heart disease will physicians will assume that must be coronary artery disease. They don't think about establishing a diagnosis of Chagas disease. So there's a lack of physician awareness. We're not doing active surveillance to see how widespread these diseases really are. And then you get to the problem of we're seeing a lot of Chagas disease among pregnant women in North America. Some estimates 40,000 pregnant women with Chagas disease passing the infection onto their babies around 5% of the time. So the CDC recently did a survey to show that the level of awareness among obstetricians was practically zero. And then you have the problem of the diagnostic tests are not readily available. So when you go get a blood test at your doctor, you bring with you a little lab slip from Quest Diagnostics. It's got a bunch of boxes checked off for your blood counts and chemistries and everything else. You don't see a box for Chagas disease. You don't see a box for toxoplasmosis. So it's not something that's made accessible. And then, of course, we don't have great treatments for that either. So, for instance, today, right now, we don't have any medicine to offer a pregnant woman with Chagas disease. So that's a big piece that has to be taken on. I think getting the state legislature, since I think Texas is ground zero of all the other states, we're seeing it elsewhere on the Gulf Coast as well. But I think Texas is the place where it's most widely prevalent. Getting it to the attention of our elected leaders, I think, would go a long way. But thank you for the question.
So we have our call to action. our final call of action. And it has been very consistent with what we've heard in the calls of action from others who've stood up there before. And we can see some of the similarities and some of the lessons that can be learned from addressing neglected tropical diseases, as well as addressing some of the diseases that are more prevalent. But what do we know too? There's some of the same messages about the level of awareness that needs to be raised, about the type of actions that we need to take. I think there's a lot to be learned between those two realms.
I think, that's why I think our organizations like TIP are so important, because the level of awareness about not just vaccinations, but all science and health is limited among the U.S. population. I have friends and colleagues at an organization I know Anna knows well, called Research America, based in Washington, D.C., not too long ago concluded a study that found that 70% of Americans cannot name a living scientist. And that study went on to show that a significant proportion of the American population believes that Albert Einstein is still active. And guess who was the most named scientist in the United States? So Stephen Hawking was, of the 30% who could name a scientist, Stephen Hawking, and number 2 is Bill Nye the Science Guy. So we have our work cut out for. 60% of Americans cannot name an institution where biomedical research is conducted, and only 9% of Americans could ever heard of the NIH. And we wonder why NIH funding has been flat. I mean, Congress reflects the U.S. population, and so there's a huge amount of advocacy and education that we need, and this is one of the big problems that we have with vaccines and autism. It's when you go to a website and Google vaccines, guess what you get? You get a lot of crazy anti-vaccine websites, and so we need to fix that. Thank you.
And thank you. So guess what time it is? It's time to get to fixing that. It's time to get to fixing that. So this is the time of the day when we bar the door. So those last people leaving will be the last people leaving, okay? And I'm going to request from you the 30 minutes of your summit that will change your lives and the lives of the people out there in terms of our ability to do just what Dr. Hotez says. Time to fix that, okay? So let's work on fixing that. So this is when I look out in the audience, and this is a pretty good retention rate for this time of a summit, for this time of day. So let's keep it about, so first of all, applaud yourselves for still being here, okay? Second of all, if you have not yet taken your name tag out for the drawing for the hotel room, then please take your name tag out. Here's my name tag. Take your name tag out of its holder and take it out. And as we're doing this last session, we will be collecting those up. And at the end of this session, we will be drawing the name, okay, for the hotel stay at the Grand Hyatt. But in this next 30 minutes, what we're going to be able to do is take everything that we have learned and start to put it into direct action for ourselves and create the script that is going to allow us to bring everything that we've done here together. So when I look out here and I see we happy few, we band of brothers and sisters who are now the luckiest people at the summit, because what we're about to do is to craft the script that we will be using when we go back into our work on some of you tomorrow morning, some of you Monday morning. What happens at a summit like this is you think that you're going to remember everything, this excitement, the motivation that you had, the inspiration that you had, but we know from the data that by Monday, 80% of what you have experienced here, you will lose if you do not do something right now to lock it in. So let's lock it in, okay? If I can get my slides up, please, Mickey. Thank you. So, declarations of commitment. We talked about the future that we want to create. We are going to start to put language to that future right now. One of the most generative speech acts we have is declaration. That is why I had you think about your headlines this morning. It is a declaration that creates the future that you want to have. It is a pure leadership speech act, and it is powerful. It is powerful. Not necessarily is grounded in data, but it acts ahead of them. So when I think of one of the most powerful declarations that was ever made, it was when John Kennedy said, we will, by the end of the century, we will put a man on the moon and safely bring him back. One of the trivia facts I love about that is at the last minute, a young speechwriter added and safely bring him back. Okay? It's way easier to put a man on the moon than it is to safely bring him back, right? But when he made that declaration, what did we have in terms of a space program? I think the technical term is bupkis, right? We didn't have a whole lot in terms of a space program, but by the end of the century, we had done it based on this powerful declaration because we can generate the future by using them. We talked about our assertions, the data we know, driving these declarations. It makes what we want known to others. This is how you're going to enlist people in helping you achieve your call, in helping you do the work that you want to do. And it is important that we ground what we do in these declarations and assertions, because what did we see earlier today from Joe O'Rourke when we saw that the fact of the matter is so many parents, 9.9% of the parents, they all valued this vaccine, but the perception, the assessment of the healthcare provider was that it was at half of that. Perceptions and assessments can kill, but they can also be extremely generative when we bound them with our declarations and our assertions so that we can make better requests and better offers of one another. Requests and offers, think about the requests and offers that you are prepared to make right now, and we're going to put them all together in our declaration. On your table, you have yellow sheets. Hold them up. Hold them up from your table so I know that every table has one. Wonderful. Distribute one to everyone at your table. If you are alone at a table, you should probably join some friends right now. Make a new friend if you're alone at your table. I am going to give you 5 minutes. I'm going to be standing by the exit so that we're going to give you 5 minutes to fill out your script. And this is important because this is the script that you are going to use to enlist people in your work when you go back. You have 5 minutes to fill it out, and then you're going to start sharing it at your table. You're going to start practicing your powerful speak that you are actually going to use in the same way that we're asking physicians and healthcare professionals to use a certain kind of speak, a certain kind of request. I'm asking the same of you. You have 5 minutes to fill out your powerful speak that you are going to be using as soon as you go back into work. Samuel, give them some uplifting music for the next 5 minutes to fill out their scripts.